It's the top of the hour. I'm Dia Waguespack in Houston. I want to welcome everyone to today's GlomCon session. Today's part of our clinical trials conference series, which is a joint venture between GlomCon and NephCure. So just a reminder of NephCure's mission, which is to accelerate research for treatments of rare forms of nephrotic syndrome and provide education and support to improve those with protein spilling kidney diseases. And as this is a clinical trials series, I want to remind you of one of the resources NephCure has is the Kidney Health Gateway, where there's a physician portal, patient portal, and family portal where you can go on to look to see what clinical trials are happening for specific diseases and near you. So with that, we'll get started with our introduction. So we're excited today to talk about lupus nephritis, talk about trial design and execution, and the lessons we have learned from this. Our speaker today is Dr. Rob Huizinga. He's the Executive Vice President at Aurinia Pharmaceuticals. He has an extensive experience in clinical research and is a leader of the research team there, which is actively involved in both clinical and preclinical investigation. He holds a Master of Science in Medicine and Epidemiology from the University of Alberta, a PhD in Organizational Leadership from Regent University, and is certified in nephrology and a member of Sigma Theta Tau Honor Society of Nursing. Before joining Aurinia, Rob was a clinical investigator and epidemiologist at the University of Alberta, Division of Nephrology and Immunology, where he was involved in more than 60 clinical trials. He has numerous articles published in leading medical journals in the area of pharmacology, immunology, transplantation, and autoimmune disease, and we're excited to have him talk with us here today. After his talk, we'll have a panel discussion. Our panelists today are Dr. Dawn Castor. She's an assistant professor of medicine in the Division of Nephrology and Hypertension at the University of Louisville. Her academic focus is on clinical and translational research in glomerular diseases. She serves as a clinical director of the University of Louisville's Glomerular Disease Clinic and a site PI on several industry-sponsored clinical trials in glomerular diseases. She's on the steering committee for the KDIGO Glomerular Disease Controversies Conference and is a member of the SONG Disease Steering Committee and on the Lupus Foundation of America's Medical Scientific Advisory Council. She does do consulting for Aurinia, Calliditas, Chinook, GSK, and Travere, and she's on the speaker bureau for Aurinia and GSK, and also has grants from the NIDDK. Our other panelist is Dr. Samir Parikh. He's an associate professor of medicine in the Division of Nephrology at Ohio State. He received his Doctor of Medicine from the University of Cincinnati College of Medicine, did his training in nephrology and medicine at Ohio State. He has served in the past as the director of the Nephrology Clinical Trials Center for 7 years. He's a principal investigator on numerous clinical trials in GN. Clinically, his focus is on caring for patients with glomerular diseases, including lupus. He's involved in clinical trial development and design in both investigator-led and industry-led sponsored trials. He was a site PI for the Aurinia phase 2 and 3 and co-investigator for the Bliss LN. He has advisory and consultant, serves as an advisor and consultant for Aurinia, Alexion, BMS, GSK, and Kezar, and his grant support from NIDDK, Aurinia, and EMD Serrano. So after that introduction, we're and all of our disclosures, we'll welcome everyone and excited to get started. So I will stop sharing and allow Dr. Huizinga to share his screen.
Well, perfect. Thanks very much. And my thanks to both GlomCon and NephCure for allowing me to speak this morning. I'm just going to take a second to see if I'm confident enough to, there we go. And we'll talk about lessons that we've learned from lupus nephritis trials, both the design and the execution of the trials. And I'm hopeful that we'll have a very robust conversation afterwards in terms of the lessons learned and how does that apply for future trials that are upcoming. And just to remind everyone, I'm an employee and a shareholder of Aurinia Pharmaceuticals. And when discussing lupus or voclosporin, it will be to illustrate a point in the discussion and not to talk about the use of the medication in lupus nephritis. I've been fortunate to see the development of voclosporin since its inception right through to NDA and successful FDA approval. And again, we're just going to talk about it to make a point in this discussion, but not to talk about the efficacy or safety of the drug in and of itself. And lastly, this talk reflects my opinions on lessons learned along the way in lupus nephritis trials and autoimmune disease, and don't necessarily reflect those of Aurinia Pharmaceuticals. We've all seen this slide from Anders and Rovin, or one similar to it. And we lose nephrons along the way with lupus nephritis. We accept the idea that we have this gradual podocyte and nephron loss with aging, but we understand the implications of a nephritic episode in the context of the patient, that every nephritic episode results in irretrievable nephron loss and podocyte damage, and that results in destruction of renal tissue and resultant loss of renal function. And so it's not only about complete renal response, but speed of complete renal response that becomes very important to us clinically. This was a talk given for GlomCon just recently in December of 2020 by Drs. Kent and Yap. And we've learned a lot along the way in terms of lupus nephritis, both in terms of how to get patients into complete renal response and the speed of the complete renal response. We've learned from hypertension trials how to effectively use RAS blockade in the context of patients with lupus nephritis. We've learned the importance of hydroxychloroquine in treating extrarenal symptoms and how that's become a mainstay in trials looking at lupus and lupus nephritis. But then beyond that, we've had to put together what I would call a Byzantine architecture, for looking at treatment of patients with class 3, class 4, 3-5, 4-5, and class 5 disease, both those who have subnephrotic range proteinuria or nephrotic range proteinuria. And our choices are to use steroid in various dosing, or to add on cyclophosphamide in either the urolupus regimen, or to add on MMF or your mycophenolic acid medicine of choice. And then beyond that, to look at multi-target therapy. And I want to draw your attention to the right-hand side of the slide for a second, because it talks about the BLISS-LN trial and belimumab. This was the landscape in front of us in December of 2020. And here's the landscape in front of us today. We now have 2 approved drugs in lupus nephritis. And I'll read their indication statements for you because there's some similarities between them, but some differences in terms of how they got there. Panelists is a BLISS-specific inhibitor indicated for the treatment of adult patients with active lupus nephritis who are receiving standard therapy. And Lupkynis is a calcium inhibitor indicated in combination with background immunosuppressive therapy regimen for the treatment of adult patients with active lupus nephritis. So you see some similarities here. We're talking about adult patients, active lupus nephritis in the context of background immunosuppressive therapy or standard therapy. But how we got there was very, very different. And I liken clinical trials to climbing Mount Everest. Now, to be very clear, I've never climbed Mount Everest, and I only have a passing academic interest in how people get there. And if you had a chance to talk with Biff Palmer, who's climbed the 7 summits, he'll recount in great detail how that happens. But drug trials and drug development is really like climbing Mount Everest. It's unbelievably difficult. It takes a lot of effort to get there. And the good news is that once you get there, you can turn around and look behind you, and there's lots of people behind who are trying to do the same thing. And that's a good thing. That's a great news for patients with lupus nephritis. After all, if we found success in lupus nephritis trial design, we should be able to replicate that success and actually improve on the results that we've seen so far to get better results for our patients. But what's interesting about Mount Everest, if we can just continue this analogy for a second, is that the death rate has increased since the 80s. And despite better ways to oxygenate ourselves there, better medications to deal with hypoxemia, better clothes, better equipment, and better resources all around, we still have issues with the death rate on Mount Everest. And what's interesting is that most of that happens upon the descent. In other words, we become very focused on a goal in clinical trial design, and sometimes forget that we have to go the full distance before we can submit a package that's appropriate for the regulatory authorities to look at. And so I say that preclinical and clinical studies fail to summit Mount Everest, and importantly, fail to descend safely from either lack of care and protocol design, poor protocol execution, and inappropriate site data. Now that sounds maybe a little bit harsh, but maybe we can learn from the lupus nephritis trials and understand what that means to us in context. Because after all, drug development is a balancing act. And typically when you look at balance scales, there's 2 aspects to them, but our balance scale has actually got 3 aspects to them. Firstly, we need to think about what the patients are looking for efficacy and safety. If you think about the early trials in islet cell transplantation, is success freedom of insulin, or is success C-peptide levels? If you're a patient, they would probably argue that freedom of insulin is the most important thing to them. And so we need to design trials that have value and make sense for patients. We need to design trials that have value and make sense for clinicians. I mean, is it complete renal response? Is it partial renal response? And when do you want to see those endpoints? And so we have to balance the needs of clinicians who are seeing patients day to day in their office. You've seen more patients clinically with lupus nephritis than I have in my old world. And while I have the benefit of looking at hundreds upon hundreds upon hundreds of patient data points in the context of a clinical trial, I don't have the patient sitting across from me in an office. And lastly, we need to take into account the needs of the regulators. Their role is to look at the clinical trial and decide whether that clinical trial provides generalizability and reproducibility that gives them confidence that in the real world, what we see in the context of a clinical trial makes sense in the real world patient population. And so there's a lot of discussion that goes on with all of these three groups and ourselves as drug developers to try to find a common path that allows us to chart a course in terms of drug development. So why have previous studies failed in lupus nephritis? Is it a lack of precision in the study endpoints? Maybe if we had chosen just simply another endpoint, that would have made our lives a lot easier. Is it the wrong population? I mean, do we need to have biopsies to prove that these are patients with lupus that have lupus nephritis? Maybe we're looking at patients that don't have recoverable proteinuria. And importantly, do we control the standard of care in the control arm? I've heard time again, when I talk to clinicians, they would say that left to their own devices, they would treat patients on both sides of a trial equitably. And I believe that they believe that that's true. But in the context of a global trial, we see variability with standard of care inadvertently, just because of either the passage of time or the passage of new information. And so controlling what happens on the placebo arm becomes very, very important to us. And I'll talk about that. So I'm going to divide what we've learned in lupus nephritis trials into three buckets, if I could. The first is variability. And my point to remember that variability is not your friend, not in the context of a clinical trial. The second is that we need to go to where the patients are clinically. And you'll note that I didn't say we need to go where the patients are geographically. We need to go where the patients are clinically. And lastly, class effect does not apply equally, that the lessons that we learn with each new molecule and its specific differences compared to others may become very, very important to us in the context of drug development. So let's talk about variability. And what is complete renal response anyways? Well, all these studies use compositional endpoints, and I'm going to use the belimumab endpoint first because they got approved first. They have an endpoint of a UPCR less than or equal to 0.7 plus an estimated GFR that was no more than 20% below the pre-flare value, or greater than or equal to 60 mils per minute normalized for body surface area, and was not a treatment failure. Now, a treatment failure included use of rescue medication, where they violated the steroid dosing protocol, the initiation of RAS blockade after week 24, the initiation of hydroxychloroquine after week 24. So there's a lot of variables that go into that endpoint. And with each variable comes the potential of variability. What about the ones used for voclosporin? Well, that was a UPCR of less than or equal to 0.5, an estimated GFR of greater than or equal to 60 mils per minute normalized for body surface area, or no confirmed decrease from baseline of greater than 20%, and received no rescue medication for LN, and not more than 10 milligrams of prednisone per day for greater than or equal to 3 consecutive days, or for greater than or equal to 7 days in total during weeks 44 to 52, noting that the renal response assessment endpoint for the voclosporin studies was week 52, and the PERR endpoint for the belimumab studies was week 104. So again, there's a lot of similarities between these two definitions, and a lot of endpoints, all having variability. Variability is not your friend. And just a very simple diagram here looks at this blue line, this orange line, this green line. They all start the same. They all end the same. But if your primary endpoint is here, if you have the orange group in your study, you have a sense of confidence as to what that result means. If you have the green group in your study, you have some variability around there, and that may be applicable in the real world. But if you're in the blue arm of the study, there's so much variability there that it becomes hard to make an accurate assessment both on the efficacy and the safety of the molecule. We've just seen this in other renal diseases that were put in front of the FDA, where the amount of variability in efficacy and safety resulted some real tension and confusion for the regulators as how to best to handle that information. So variability is not our friend. So that's a very overarching 50,000-foot view of variability. And I want to take just a few minutes to dive into some very specific points that become really important for us. And I put them in 3 buckets: statistical variability, sample variability, and study variability. And in all 3 of those, you need to decide in advance how you're going to deal with that variability. So let's talk about stats just for a few minutes here. I mean, obviously, if you have missing data, you need to deal with that missing data endpoint in some fashion. And you can do simply a mean imputation. We all understand what that means, right? You look at the average, the mean in that group, and you fill in the missing data with that mean. It does a wonderful thing of reducing variability because it drops the standard deviation dramatically, but you get regression towards the mean, and that may not be appropriate. You can do last observation carried forward, which has really fallen out of favor in most studies because it doesn't really help us statistically understand what happens to the missing analysis. You can do endpoint failure, where if the patient doesn't show up for the visit, as has been done in lupus nephritis studies, that they're automatically considered a failure. You can do an MMRM model, so a mixed model for repeated measures, that allows you to look at random effects and correlate residual error. But I want to talk about something new that the FDA has asked for, which is becoming very important to us, and it's a very powerful statistical tool to deal with variability and missing data. It's called a tipping point analysis. So a tipping point analysis is a valuable tool for sensitivity analyses, and it's a valid statistical inference without the need of imputation. And so what we do is we take the primary analysis and repeat it under all possible scenarios for responder status. In other words, you take the missing patient data, so the missing patient in this case, and you assign it a responder or non-responder status, and you rerun the analysis. And you do this for each missing patient. So let's just look at this example graph here. If you go to the bottom along the x-axis, you see that vertical line somewhere around 72%. You follow that vertical line right up. We'll see if my cursor works here. There we go. Right there is the estimated response rate for the treatment arm of about 72%, and the estimated response rate for the placebo arm somewhere around 63%. But there's missing patients in this data set. What if the missing patients on the placebo arm were actually all successes? How would that have impacted the analysis if we could find those patients? Well, the way we do that is we assign them a success ratio, and they will impact this vertical line right here. So in this case, we added a few more patients. The response rate went from 63.3% to what looks like about 65% or 64%. And that dark shadow, that dark line that you see there, is the line where the p-value drops higher than p.05. In other words, we lose statistical confidence in the results if we add these missing patients and assign them a response rate of being complete renal response. And you can do this for all patients. In addition, what you can do is you can start working with the different response rates on the control arm or on the treatment arm and say, if we had 5 fewer patients on the treatment arm, what would have happened? So how do you read this, not having to delve into stats all the time? It's actually easier than you think. That black band that you see there, in the context of clinical trials, you want to see that black band pushed up and to the left as far as possible, because it means then you'd have to have more clinically improbable situations in order for the study results not to be valid anymore and not to have statistical certainty. So that's how we can read tipping point analyses. And they're a valuable tool for us to deal with missing data and thereby decrease variability. And importantly, understand the conditions in the real world, how robust these data sets are for us clinically. There's another way to look at it. I like the term strength in multiple dimensions. In other words, if your primary endpoint has generalizability, you should be able to cut the data in different lights and generally see the same answer. This is a forest plot. It's one of my second favorite tools now because my new favorite tool is a tipping point analysis. But a forest plot is extremely valuable to us. So if you've never seen one before, they're really easy to understand. If you see that dotted vertical line at 1, that's a line of unity. Right there, we can't tell if the active drug is better than placebo. If your diamond, you see there, or your square box at the bottom falls to the left, it favors placebo. And if it falls to the right, it favors your active drug, whatever your active drug is. And you can see with the diamonds, because these are sub-analyses, that you have the 95% confidence interval associated with that point prevalence there. And so if the 95% confidence interval lies entirely to the right, you actually not only have some confidence clinically, but you have confidence statistically that the result is valid. So what do you do then if the line crosses the line of unity? I'm going to get you to focus right at the bottom of that slide there for a second, and at maximum MMF dose, in this case, where the MMF dose is greater than 2 grams, and you can see that the diamond falls to the right, but the confidence interval crosses the line of unity. And so you don't have that statistical confidence that you were looking for. Well, you can look at the sample size. In this case, it's a sample size of 44. And as we know that as sample size decreases, variability increases. And so this is an issue of not having the sample size needed to have the statistical confidence to make a statement around this. Does that mean it's not valid? Well, that's not necessarily true. Remember that clinical trials are designed with the primary and potentially secondary endpoints in mind. And to increase statistical surety, we add patients to a clinical trial. And I can tell you that lupus nephritis trials in and of themselves are quite expensive trials to run on a per patient basis. And this has nothing to do with, how much we pay investigators and our investigative sites to do these trials. It has to do with all the work involved around a clinical trial. We spend a lot of effort using the right central lab to decrease the variability in lab endpoints. We use the right clinical research groups to understand that we have confidence around the data sets. We use a lot of analytic tools, which I'll talk about in a few minutes, to get a good sense of the data. So adding more patients, while statistically it makes a lot of sense, it also doesn't even make sense clinically because it would add to the length of the trial enrollment and would delay our opportunity to see results in a timely fashion. So when you look at forest plots, they're very helpful to us. As you can see in this case, the diamonds, all the sub-analyses fall to the right of the line. So it gives us some confidence that in conditions that you might see in your clinic office, this drug, in this case, should have value in those patient indications. So that's statistical variability. Let's talk about sample variability for a few minutes. I mean, how do we best measure proteinuria? I think we would all appreciate that a 24-hour urine collection probably, if it's accurately collected, probably is a good way for us to look at proteinuria. And you can do a truncated collection, an 8 or a 12-hour collection if you so desire, knowing that as we decrease the sample size or the sample collection length in this point, we increase variability. Well, so 24-hour urines are helpful to us, but they're not necessarily practical in the context of a global trial. Well, how about a spot urine protein creatinine ratio? They have a lot of variability to them. And we know that spot urines, while they may have value clinically in an office, in the context of a global clinical trial, they're extremely unhelpful. Well, where else does that leave us in terms of options? Well, maybe an option is a true morning collection or first morning void. And we know that in the context of some of the trials that have been done, if we look at the context of a true first morning void, so an adequately collected first morning void, compared to an adequately collected 24-hour urine, that we see great correlation to those points. I'm going to focus your attention to the bottom left side of the slide here, remembering that if your endpoint is 0.7 for a UPCR, 0.5, there's a great correlation between first morning voids and a 24-hour urine. And so there's an opportunity for you then to use, let's say, for example, a first morning void or an AM collection, however you want to look at that, instead of always having to do 24-hour urine. There's other things to think about. Do we do just a single or do we do a confirmed collection? Some of the trials in lupus nephritis have done 2 collections to confirm that the UPCR change was real and not variable. Some have used 2 collections up front. Some have used 2 collections at the endpoint. And what's important, and I'll come back to sample variability in just a few minutes, is that someone is overlooking these results and making sure that they have clinical validity. So that's an efficacy endpoint. What about a safety endpoint? And we've had lots of discussions how best to measure renal function. Do we use eGFR? Do we use serum creatinine? And even over these last couple of weeks, as we've seen comments around these lupus nephritis trial results, we've had a lot of conversations around eGFR and serum creatinine, or maybe we need to do slope of eGFR. What's really important is that we have a really good assessment of the patient's baseline renal function coming into the trial. Well, why is that? So this is data from a trial looking at the placebo arm, and you can see their eGFRs over time, and you can see the variability in the placebo arm of this trial. There's immense range running from eGFRs of 50 to 150, and within each patient, this is a spaghetti plot, you can see the extreme variability. So our ability to accurately measure renal function becomes very, very important. We've all seen the means plot on trials over time, but this is looking at that data in a slightly different light. And so our ability to normalize or minimize that error becomes very, very important to us. So that's sample variability, that's statistical variability, but I'm going to talk about a big area that we don't always mention, and that's the study variability. The first one is steroid dosing, and I've had a lot of jokes over the past several weeks that small land wars have been fought over steroid dosing. When the studies were started in lupus nephritis, the amount of steroid given caused a lot of consternation and controversy and argumentation, and you can imagine in the context of a global trial how difficult it is to get consensus on steroid dosing. Variability in steroid dosing, I think, is one of the biggest causes of trial failure that we've seen over the past while. And so getting investigators, regulators, and the company to agree on to what steroid dosing would look like becomes very, very important to us. And at least standardizing between arms becomes an important step for us. And the second is RAS blockade. Whether you choose to insist on RAS blockade at the beginning of your trial and choose to insist upon no change during your trial, I think both approaches can have merit. But to not talk about that and to leave investigators to their best intentions and their best hopes would allow variability. And the last one is actually adverse event definition, which we rarely talk about in the context of a clinical trial. A rheumatologist's definition of acute kidney injury and a nephrologist's definition of acute kidney injury are two very different definitions. And so we need to find some mechanism to provide guidelines for what adverse event term definitions mean. And it's a mechanism to help investigators understand what is the right term to use when they see a patient in clinic and something's going on and they need to provide an adverse event term towards that. And that'll allow us then in the analysis to look at what those adverse event terms are. But the other thing that I want to go back to is this idea of diligence, diligence, diligence. It's not enough for us to collect this data, analyze the data, and report the data. We know that in the context of 24-hour urines, somebody from a nephrology background needs to go through every individual patient's 24-hour urine numbers to see if they make sense. And I'll give you an example. If you just look at the 24-hour urine values from the lab, was it really a 24-hour collection? Was it an 18-hour collection? Was it a 12-hour collection? They're going to report the data point that you've asked them to report to, but someone needs to look at that collection and see if it's really real and if the volume of urine makes sense. And so somebody with a nephrology background needs to go through this. So this is an example of an analytics program that we've used in the past. And you can see on the top here, here's a patient's protein creatinine ratio. You see it goes from a high of 5 at the beginning of the trial, drops down to 0.5 easily. But look at that spot in the middle there. It just sort of pops up on its own, pops up to about 1 gram. And so what's going on there? You see their eGFRs are stable. You see their creatinine is stable. There's no change to their potassium, no change to their magnesium. And so over that, you have to lay their concomitant medication and see if there's concomitant medication that may have impacted that UPCR value, or whether it's just truly an aberrant UPCR value. And that means patient by patient by patient, you have to go through all the data as a team and run through it both from an operations point of view, a science point of view, and from an immunology point of view, and to see if this data makes sense. And it's your opportunity during the trial to talk to investigators saying, we see this data point, and it doesn't make sense to us, and we're removed from the patient. Can you just walk us through what you think this means? That offers the opportunity to decrease variability within the data stream and allow us to have a much clearer picture of what's going on. So that's variability. The second part is to go to where the patients are. The populations that we're talking about need to be representative of the populations that you intend to get approval for, the drug company, or the populations that you're looking to treat in your office. And that means that we really need to have African-American patients, Hispanic patients, Caucasian patients, and Asian patients. All of those demographics need to be adequately represented so we have a sense of confidence into the trial results. And knowing that lupus nephritis disproportionately affects young women of minority, we need to make sure that we have those patients represented in our clinical trials so we can interpret the results in a broader spectrum. But the second part is active lupus nephritis. I talked about this at the very beginning. Is a biopsy really needed? We know that 5% of patients who have lupus don't necessarily have lupus nephritis as the cause of their proteinuria. And so a biopsy is needed. And you need to decide what classes of patients you're putting in your trial. Are we putting class 3 and 4s, class 3 through 5s? And additionally, how proteinuric should these patients be? Is it a gram or a gram and a half for study entry? And all of these have an impact on the study endpoint. And so if we looked at the two approved drugs, Benlysta and Lupkynis, they were basically all-comer trials. The Benlysta trial had failures of cyclophosphamide, MF excluded, and that makes sense because they used the MMF and the Eurolupus and the Alms regimens in terms of the control arm. But these are patients that were nephritic, that were biopsy proven within the last 6 months. And in the case of the Lupkynis trial, a window was allowed for a longer biopsy period, provided there were other clinical indicators of active disease. These were class 3 through 5 patients. In the Benlysta trial, they had MMF or cyclophosphamide AZA. In the Lupkynis trial, we had MMF. The proteinuria was a gram for the Benlysta trial. The proteinuria for Lupkynis was 1.5 or 2 grams for class 5. The eGFRs were greater than or equal to 30 mils per minute for Benlysta, 45 mils per minute for Lupkynis. And in the Benlysta trial, RAS blockade was recommended. And remember, I talked about this earlier, no RAS blockade changes were allowed after week 24. And the Lupkynis trials, no change to RAS blockade was allowed during the context of the trial. So they're slightly different, mostly the same, but those nuanced differences may make a difference in how we look at the endpoints. And it's important to remember that patients enrolled really needs to equal patients completed. Looking at the data externally from a sponsor point of view, it is really problematic when we have those missing patients, and then we have to go to these tipping point analysis. We have to do the MMRM analyses to try to look at the impact of missing data. We know there's geographic variability in patient completers. We know there's geographic variability in compliance with the protocols and treatment for diseases outside the context of the protocol. And all of that needs to be taken into context as we're designing the protocol. Remember, I said we need to go where the patients are clinically, not necessarily where the geography is helpful to us. And the third point of my talk, class effect. Let's talk about BAFF just for a minute. We have 3 drugs in this context that we can talk about: belimumab, blisibimod, and tabalumab. And I'm going to talk about them in the context of lupus. So why lupus and not lupus nephritis? Well, we have a lot of trials that were done in lupus. These 3 were studied in lupus. So it makes it very easy for me to make an analogy and a comparison to you. So consider belimumab just for a second. Belimumab is a monoclonal antibody that binds specifically to soluble trimeric BAFF and potentially to membrane-bound BAFF. Blisibimod is a fusion molecule that's composed of human IgG1 and 4 BAFF binding domains. And tabalumab at the bottom there is a monoclonal antibody that binds to both soluble and membrane-bound BAFF. So what happened in the context of their clinical trials in lupus as an analogy? Well, we already know that belimumab received approval in 2011 on the basis of their 2 large trials in patients in SLE receiving standard therapy using the SRI-4, so the SRI response rate, the SRI-4, and looking at the response rate, also in addition reduced SLE disease activity and severe flares. Blisibimod looked at a phase 3 trial with active SLE and used an SRI-6. And the delta between medication and placebo-treated patients was 4.6%, so not a robust treatment effect. And tabalumab, which is very similar to belimumab, showed efficacy in one trial using an SRI-5, and the other trial showed trends, but differences amongst groups that did not reach statistical significance. So what's going on there? Well, there's things that's considered that we've just talked about. The difference in endpoints and the timing of endpoints is very important to us. Is it an SRI-4, an SRI-5, an SRI-6? But there's issues to consider beyond that. And we need to think about potency and pharmacokinetics and pharmacodynamics. Glycosylation of an antibody impacts its ability to bind and certainly impacts the PK of the molecule. And so we have to look at potency and PK/PD and trial endpoints. And just because all three of these are very similar in terms of their effect, only one of these made it across the line in terms of lupus. And so my encouragement to us is that we have to stop thinking about class effect and using that like a broadsword across clinical data, but rather think about the individual peculiarities or treatment benefits of an individual drug within that class, and then apply that in our learning for lupus nephritis trials or other proteinuric kidney disease trials. So we've learned that variability is not our friend. We've talked a lot about different ways to decrease variability. We've talked about how we need to go to where the patients are clinically, because that's important for us treating these patients when we see them in the office. And lastly, that class effect does not apply equally. Before I stop, I want to give a huge thank you. Drugs are developed on the back of relationship, and great drugs are developed on the back of great relationships. And we can't do this without everybody on the call here. We can't do this without the patients who willingly agree to be involved in clinical trials. We can't do this without the investigators who come alongside us as partners to help us develop a medication. And we can't do this without the regulators who help us understand the generalizability and reproducibility of the trial data that we have and the implications in the real world population. Those communities coming together allow us to make a difference in patients with lupus nephritis. And just as a last closing thought, we have what I would call a renaissance in nephrology right now. We have more nephrology professionals in industry, in the regulatory bodies, and in research organizations than we've ever had. And it's an opportunity for us to make a difference, not only in lupus nephritis and other proteinuric kidney disease, but other renal diseases for which we've struggled to find a difference. And with that, I'll end with this slide. For those colleagues of ours who are still doing trials in other proteinuric kidney diseases, including lupus nephritis, my encouragement to them is to keep on going. We've found great success with these two new molecules on lupus nephritis, but we're still only partly there. We have room for improvement in terms of complete renal response rates. We have questions open to us about what happens over 3 years or 4 years or 5 years or 10 years. And not all of those things are solvable in the context of a clinical trial, but there's lots of room for us to improve and to continue in the care of patients with these kidney diseases. So I'm going to stop at this point. Thank you so much for this opportunity, and I'll turn it back over to the moderators.
Thanks so much, Rob, for bringing to light so many of the challenges that we face with doing these trials. We as investigators, as clinicians, and as researchers in industry, I think overarching theme of all of that was the variability in all regards, right? Not just in the actual trial design, but in the patient populations, our treatment. You brought up standard of care and how standard of care is, you know, our old standard of care may now be changing, and we want to talk a little bit about that. I think we'd like to bring in Dr. Parikh and Dr. Castor to comment too and start some discussion. I think there's a lot we can definitely talk through, so we'll get through as much of it as we can. But I think starting with kind of the topic of variability in the actual trials, I mean, I think it's important, I think questions from the chat too, just to touch on both of your experiences with not only the proteinuria, but endpoints. And you know, you brought up endpoints that how they're different in both trials. There's the endpoints we talk about with patients, which look in you know, cohort and studies portend a better prognosis going forward. And so how can we best as a community come up with even, you know, overall standards of how are we going to go forward with not only trial design, but then what is the FDA looking for and that type of thing. So if Dr. Parikh, if you want to start with just talking a little bit about the endpoints and your thoughts on that.
Yeah, I think thank you. First of all, Rob, that was a great talk. And thank you for having me be a panelist here today. It's nice to be with you guys. I think there's a lot of questions surrounding endpoints, and it's been an evolving conversation over the last decade or so. I think it's really led to a lot of issues with previous clinical trials. There's been heterogeneity across the trials in terms of their endpoints. And in some cases, that might have led to negative studies that might have otherwise been positive if we kind of relooked at these studies. If you think about the Access trial and things like that, where the endpoints were quite strict. So here, we have two trials that got FDA approval. They use slightly different endpoints and not just the endpoints of proteinuria, which is, the one marker that we have in lupus nephritis that seems to best correlate with outcome, but also time period, right? So 52-week trial, 104-week trial. And we tend to kind of take this approach of saying, well, how do we compare these two drugs now? And are they the same? And you really can't, right? Because these are two very, as similar as they are because of the population, they're two very distinct and different trials. And they're, if we take the PERR from the belimumab study and the 0.7, and that's taking into account more recent data from, basically retrospective reviews of prospective trials that kind of found that if you had 1 year proteinuria levels of less than 0.7, 0.8, you tend to have good 10-year prognosis, right? And what is important to a patient? At the end of the day, we can argue about proteinuria level, but at the end, what a patient cares about is how am I going to be? How healthy are my kidneys going to be? Long term, right? That's what we should be caring about, is what is the long-term outcome for our patients with lupus nephritis and preserving kidney health, and which in turn preserves cardiovascular health, are the things that we should be looking for. So when we think about endpoints, and I definitely want Dawn to weigh in here, but when we think about endpoints, we should be really focused on that ultimate goal as one part of it. And the second part of it is, in line with that, is what are we doing to prevent relapse in disease? So I think those are the two things that we really want to focus on, and the metrics that we use to get there. Right now, proteinuria seems to be the best marker that we have to predict those kind of outcomes. But there may be other metrics in the future that we can apply to kind of help us get more specific and better tell us and aligned with patient heterogeneity that we deal with lupus nephritis.
And Dr. Castor, if you can kind of chime in on your opinion on the endpoints, I think, and kind of lead into to even a point you'd brought up previous to the session was about remission and remission rates. And I think those all kind of tie together as far as what we're looking at when we're getting approval from a trials perspective, and then translating to what Dr. Parikh had said.
Yeah, I think Samir, you summarized that very well. And I agree that ultimately, as a nephrologist, the endpoints that matter the most to me are, that these patients are going to have good long-term outcomes, good long-term kidney function, and avoid end-stage kidney disease. So we don't fully understand, which endpoints are the best to meet this, other than proteinuria. So in the past, a lot of prior studies, looked at urine sediment, looked at a much stricter definition of complete response rate. But it's still not uniform. So I think if you talk to 3 different nephrologists and rheumatologists, how they define complete and partial responses in lupus nephritis is going to be highly variable. And moving forward, it would be helpful if we came up with better definitions of what these are. That being said, the complete response rates for lupus nephritis are still very low, even in the clinical trial setting, less than 50%. So there's a lot of room for improvement. And we know in clinical trials, patients are much more adherent than they are in real life. At least that's been my experience. There's a significant unmet need for these patients moving forward. And I think making it more unified. Time is also a big point. A lot of the failed trials before looked at 6-month endpoints, which may have contributed to their failure. So I think this 52-week, 104-week, while it's feasibly difficult, to do a trial that's longer, at least in lupus nephritis, it does appear that we've had 2 successful trials that were longer.
Can I just add something to what Dawn just said? And I think it's really, we talk about remission, right? And complete response, partial response, somewhat arbitrarily defined, right? And at least, we don't even if you look at our guidelines, KDIGO, EULAR, ACR, some of which need to be updated, they're not uniform across those guidelines either. So it leaves a lot of confusion to the practitioner, to the patient, to everybody, to the industry in terms of what, and then also to the FDA, to the regulators in terms of what we should be using as important metrics for outcome, right? And I think when we think about the data that we have available, we should always be trying to strive for the best response possible, right? And because at least in the data that we have, it suggests that partial responders, and we take total response as a metric in some trials, there's a big difference in terms of outcomes, long-term outcomes between those who are partial responders compared to complete responders. And the other thing we have to highlight is the limitations of proteinuria as a metric. It means a lot of things and it means not a lot of things, right? So it can reflect disease activity, it can reflect chronicity. I think, this is where it comes back to, what are we actually treating, the heterogeneity of the disease, heterogeneity of the biopsies, all of these things come into play. And maybe part of the reason why our response rates in clinical trials and otherwise is because it's really hard in lupus to get a homogeneous population of patients. There's so many factors and variables that go into play there. And it's reflected in the outcomes of these studies, and we don't have the best metrics, and we have to merge real life. Like, how do you enroll a trial if you're trying to have a 3-month, 1-month biopsy window, or you're going to do a biopsy at the time of enrollment when they just had one 6 months ago, but that 6-month window where they might have been on MMF for that period of time might have impacted the molecular profile of these patients. And so there's so many thoughts that go in there. It's just adding to a lot more questions, unfortunately, than we have answers for just yet. And so, there's a lot of active research, of course, going on in these areas, but it does highlight the challenges that we face when we try to do online trials. And not surprisingly, maybe informs why so many of those trials in the past were failures, right? And then the last thing I want to mention was about timing of trial. I think a lot of that is dependent upon the therapy that you're using. So if you're using a potent anti-inflammatory therapy, maybe your shorter trial duration might be appropriate. If you're using a B-cell directed therapy, maybe your longer trial duration might be appropriate because the action of the mechanism of action of the drug and the timing, and perhaps maybe that's why LUNAR failed so many years ago, was because it was too short of a trial. That's certainly been a discussion point. And so anyway, I'll stop there, but I think those are thoughts that always come to mind when we have these discussions about lupus nephritis clinical trials, at least in my mind.
Thank you. And I think one of the things you brought up that's come up in from a couple of people in the chat is about biopsies. And I know you feel strongly about the biopsy perspective. So if you could, comment a little. I think the questions are, one is, can we use it for remission? There was a question that I think relates to biopsies in the sense of, genetic histologic markers. I know with, the renal biopsy databases that we're trying to now build with the hopes of the future. If you can comment a little on that. And then if Dr. Huizinga could also say what challenges, as we all know as investigators, have faced, but from the industry side and trial design of incorporating these biopsies into trial design.
Yeah, so I'm happy, obviously. I've spoken or written a lot about kidney biopsies and the value. And I realize that there's limitations too, but I just think it's really important, right? So when we're thinking about the picture of a patient that comes in with lupus nephritis, understanding what's going on in the tissue, that's ultimately what we're trying to target, right? You can, is to arrest that process that's going on in the tissue, to limit the amount of chronic damage that accumulates, which we know occurs quickly. And if we don't understand what's going on at present, how do you know that patient 1 who had a biopsy done a month ago is the same as patient 2 who had a biopsy done 6 months ago, of which that patient 1 or patient 2 might have been on 6 months of treatment coming into a trial. And I think so trying to get that information up front is very important. I think that the counter to that is to say, well, it's not going to, at least in clinical practice, it's going to be like, well, it's not going to change how I treat the patient. They came with proteinuria, hematuria, low C3, C4. They clearly have active lupus. I am going to treat them with mycophenolate and steroids, and I get that point entirely, right? But at the same time, when things don't go the way we want them to go in clinical practice, and patients don't respond as readily as we'd like them to respond, which happens a lot, then you are left with a lot of questions. And at some point, you're thinking about, well, when it would have been nice to have that information up front. And I think there's a lot of value sitting down or at least talking with your pathologist and kind of looking at the tissue if you can and getting those activity chronicity markers. There's limitations with them, but they provide some context. And, you know, we only have proteinuria as a guide. And then the second part to that is how do we use biopsies as a remission endpoint? Can we? So there's a lot of things that we don't know yet because we have dogma suggests that, you know, we know enough clinically and we don't need to do kidney biopsies. And I think that's an evolving conversation that suggests that maybe we don't know as much as we think we know. But there's some emerging data to suggest that these histology markers on the back end might actually inform relapse rates and things, and potentially which could impact long-term outcome. I think more needs to come out about that. It would be really nice to have non-invasive biomarkers to help us reflect the kidney biopsy, and hopefully that'll come in the future. Certainly there's a lot of people looking for those markers, but I think there's value at both the beginning and potentially at the end. But one other thing and food for thought is, does anyone really know the tempo of healing in the kidney after treatment and after an acute disease occurs? I don't, and I think it's disease dependent probably, but we know chronic scar develops quickly, but is it a 6-month time point, a 12-month time point, an 18-month time point? When is the right time to take another look if we're going to take another look? So anyway, those are just comments for food for thought. And I certainly want to hear what Rob has to say about the challenges that they faced in clinical trials, for sure.
Yeah, I mean, just getting back to the concept of variability again, I think there's value in histology for us in clinical trials. And how do we do that in a way that decreases variability? In other words, do we allow the local pathologist to read the biopsy and then potentially investigator may or may not make changes of therapy based on the biopsy results? That's always concern number one. Concern number two is the potential differences between a local pathology read and what we call the golden read. In other words, a central pathologist. And I see Dr. Soles is on the line here, and him and I have had personal experience with doing trials in transplantation where you have a local pathologist and a central pathologist trying to get some synergy between those two thoughts in terms of pathology sometimes can be very difficult. And then the last thing to think about is there are countries where pathology is not done routinely, so we have to take that into context. And there are other countries that don't allow for the removal of those tissues from those countries. So in those countries, do we say, okay, we'll set up a second read for those patients? You know, I know people on the call here, including Dr. Soles, have great experience in doing telepathology, so doing it remotely, and maybe that's the way for us to do it. Those are all issues in terms of variability, and we've struggled with that over the years because we see the value of the histology, we really do. But trying to do that in a way that allows for decreased variability so we can get to what the sense of what your answer might be has always been a struggle for us.
Thank you. And then Dawn, if you could comment a little bit about, you know, you're on some of these organizations and committees. Is anything being done from, you know, as your own clinical investigation into how we can better standardize or come up with some guidance on how to design trials, not only from the industry side, but is there some talk about how we can do this so that, you know, some of these questions that we're bringing up can be better answered now, knowing we may not have the data to support what we're moving forward with, but how can we better do that?
So you bring up a great point, and I've found in the lupus nephritis community, there's the nephrology lupus nephritis community, and there's the rheumatology lupus nephritis community. And I've started to kind of delve as a nephrologist a little bit more in the rheumatologist community. You know, this was my first year because it was virtual at seeing part of ACR. Usually ASN and ACR are within weeks of each other and often at opposite coasts, so it's kind of hard to attend both. But unfortunately, those communities don't necessarily talk to each other as much as they should. So, KDIGO is, kind of forming its separate guidelines. I'm not sure, and the updated guidelines should be coming out anytime. And then ACR, their guidelines were about the same time in 2012. And I'm not sure when those are being updated. And of course, the UR, ERA, EDTA, that's a mouthful, guidelines are the most updated guidelines that we currently have. No, I think this is a great thought, and really we need to get the international rheumatology and nephrology communities together to be a little bit more uniform with this process.
Dia, can I just add something?
Yes, go ahead, Rob.
If I can encourage the community online here, those guidelines are so unbelievably important to regulators, right? They're basically looking for a distillation of the wisdom of the group to say, these are important things for us as clinicians. And then the regulators can use that. And that gives them some groundwork to start from, or a landing place to start from when it looks at evaluating new trials in these kind of diseases. So, we think of these guidelines, I used to think of these guidelines as just being helpful, let's say, to me and understanding what's going on. They're very helpful for regulators. And so their importance has really escalated over the years, especially in difficult to treat diseases. So, as we continue to work them, just to remind ourselves, they've become really important for the regulatory bodies.
Thank you. And I think one of the points that brought up that goes back to the proteinuria was, the correlation between proteinuria and GFR change. And I know we've kind of touched a little bit on that. And then Dr. Glassick brings up the point, I think, of, using calcineurin inhibitors and is the timeline and the point. And I think it goes back to, again, with these trials and some of the things we've seen of, is it a long lasting effect? And those are things that I think we still probably could have more information on and more longer term data as we go along with that. The other thing I wanted to bring up, we're getting close to the end of the hour, is about standard of care, and is it going to be changing, right? So our current standard of care and our guidelines are based on drugs that are not FDA approved for lupus nephritis, and now we have 2 drugs that are FDA approved that are put on top of a standard of care for based on time and history and that type of thing, obviously. But are we going to be changing that, and is that going to complicate some of our trial design as well? So if Robbie, you can start by commenting on some of that, and then we'll let Samir and Dawn chime in.
Yeah, I think the term standard of care has changed dramatically over the last 4 or 5 months, right? We now have 2 drugs that are seeing higher rates of clinical response than we've seen in the past. And so I think for the development of new trials, you will have to come to some kind of consensus. Am I going to use the background of care that has a T cell drug or with a B cell drug? But you certainly having to have additive therapy. And we've learned this in transplantation, that small amounts of drugs put together is better than a large amount of one drug, potentially, in terms of efficacy and a safety profile. So I think it will make a change in terms of what the standard of care will look like. I still think we'll see a lot of questioning around which those 2 paths to go. And I think it's going to depend on the drug that you're developing. And I think additionally, there'll still be the question of, if I use, a B cell drug as my standard of care, am I doing that in the context of cyclophosphamide or MMF? So I'd like to say it's going to make our lives easier because we have these 2 new drugs. I'm not sure that's actually true. I think it's going to make us, sort of have to wander a path for a little bit and try to find consensus. But certainly these have impacted what standard of care should look like.
Yes, I kind of go back to what Dawn said earlier, right? So we have 2 drugs that are FDA approved therapies, and it's going to make clinical trial design more challenging for several reasons. But we also have this huge population of patients, despite the therapies, that don't respond accordingly. And we're not, 50%, 40%, that's not where we want to be, right? So if I tell you have to take 10, 12 pills a day for a year to get a 40 flip of a coin chance of responding, that's not where we want to be, right? We want to be at a place where we're at 80, 90% of patients are responding with the least amount of therapy that they need and the best side effect profile. And I think these are kind of the holes with where we are still. And as we move forward, maybe clinical trial design has to get more creative maybe it's a smaller population of patients that are that's enriched for a certain population of LN or something like that, and where we're using newer therapies to kind of add on. But we have therapies now that patients are going to be required to take 2, 3, 4 different drugs, perhaps with lots of pills. They're not cheap. And how do we go about doing that, not putting that into clinical practice? It's one thing to do it in a trial setting, but in a clinical practice, and remember, this is a 20 to 30-year-old female, mostly, who's having to take all these therapies, previously was maybe healthy completely. And it's a shock to their system. So, and it becomes a lot and overwhelming pretty quickly, I think, as you sit and talk with these patients and you think about what's important to them, which I think is something that we all have to always consider. That they want to get better, but they don't want to be broke, and they also don't want to be sick all the time with the medicines they're taking. So these are things that we'll have to figure out. I think it's going to make it very challenging for clinical trials going forward, but at the same time, it's a good problem to have because we have more tools in the toolkit, right, that we can use. So
I actually also wanted to bring up another challenge with clinical trial design with having 2 FDA-approved drugs is, the ethics of the design. So for the first time in the IRB approval, I recently submitted a new lupus nephritis trial, and you have to make a risk-benefit statement. And all my prior risk-benefit statements always said there is no FDA-approved drug for this treatment. And I had to change that because now we have 2. And then I saw from the chat, someone brought up SGLT2 inhibitors, which, are also going to be a huge consideration in trial design for any glomerular diseases. Now, the caveat for that is, I think the approval is in chronic kidney disease. So you have to have some reduction in GFR, but certainly a lot of our lupus nephritis patients still fall in that category where these treatments may benefit them, and that can also alter study design. And I'm gonna turf this over to Rob. How do you feel like these things are gonna affect future study designs?
I'm going to throw it back to you guys, and I'm going to say, the more consensus guidelines we have on what we think are important. I like the idea of looking at enriched patient populations, but if we use enriched patient populations, then we have to agree on a surrogate that we think is important clinically, and then we have to get the regulators to agree that they also agree that that surrogate is important clinically, right? Yeah. So I think more that nephrology and rheumatology, as you correctly pointed out, as the more we can get together and find some consensus on these guidelines, it will make clinical trial design easier again. Until we get to that point, it's just going to be difficult, like I said, with the risk-benefit statements that we have to now apply to these things. And that is even in the context as we're thinking about future trials in proteinuria kidney disease. How do we weigh those things off?
It's a good problem to have more medications to treat these diseases. So I'm appreciative of these advances in nephrology, but it does make future trial design a little trickier. And I think also whether to exclude some of these therapies, add them in. Obviously, we want less variability. I think this is all important for future thought.
And I think just to highlight, it's like we're early in all this, right? So we have these 2 therapies. You have obinutuzumab, who's into phase 3 and had a positive phase 2 trial, and several others that are already in clinical trial that may come down. But real world application, real world data is ultimately going to drive a lot of what happens, I think, with time. And so we have, I think, the Aurinia stuff, there's still long-term follow-up stuff that needs to come out on that. And then there'll be real world application of these therapies, and people will, I think, and that'll help inform guidelines and standard of care too in the future. So real world studies that will come out later. And so all these things are really important and relevant to the conversation. We're a little bit early in all of this. It's going to evolve. And hopefully, there's, as Rob pointed out, we need better metrics, right? The work in the lab has to pan out at some point where we start to identify some things that, markers, that really help guide us in better understanding disease activity above and beyond things that we know are imperfect. Proteinuria, complement, things like that. And so, we want to see those types of things will really help inform even future clinical trials, I think, going forward.
Yes. Thank
And-
you. Go ahead, Dawn.
I was just going to say, I've seen a couple things in the chat about stratifying patients based on genetics. And, I think there's a lot of great research in this area, but it's not ready for prime time yet. And, lupus nephritis, it's categorized as, SLE is categorized as one, disease, but what gets a patient there is a combination of very complex genetic, environmental, contribution to what led to the disease process. And in each individual patient, it's a different process, and there might be a different immune response for those patients. And as we are able to tease this out in the future, we might be able to stratify patients. Hey, this patient might respond better to B cell therapy. This patient might respond better to a T cell therapy. We're not yet there, but I hope in my lifetime as a nephrologist, we're able to get there.
I actually think the motivation to get there is higher now because we have T cell drug, B cell drug, things like that are out there so that we can identify which patients would best respond to the therapeutic choices that we have available. And so I think the drive and the need for that is greater than it's ever been because we're getting down to therapies where we've been previously using extremely broad therapies. And we're gonna, as more and more tools become in the toolkit, maybe we'll be able to stratify our patients better. And I think there's a greater need for that than ever before. So, yeah. So it's as I mentioned, we can all talk about this for a long time. So you're gonna have to cut us off at some point.
No, I think we'll stop now with those. I think there's, overall, going back to what Rob said earlier, I mean, I think variability is a key word, but I think there's so much in the pipeline from the, two new drugs that are approved for use, some promising phase 2s that have moved on to phase 3, some ongoing phase 2 trials that are active now, what's happening in the translational research world to better help us understand the disease process, like Dawn commented on. And I think this is exciting, particularly, most importantly, I should say, for our patients, because we've all treated them, and lupus is a bad disease, and the more we have in our armamentarium to help them, the better. So I thank each of you, Rob, Dawn, and Samir, for joining today, and everyone who joined and participated through the chat. To help us kind of, like you said, this is early, Samir, but it's good to be talking about it in a big group, and so we can all better what we're doing and improve the care of our patients.
Yeah, thank you for having us. It was great. Appreciate it.
Thank you, guys. We'll see everyone next week. All right. Bye.